let's just go through this developing world ultrasound. I want to start really right at the beginning, where point of care ultrasound really, or point of care imaging really started. And it started in 1914 with Marie Curie, the twice Nobel Prize winner. She'd fallen out of favor in the French society because she had an affair with a married man. Her husband died early and she had an affair. And she reclaimed her position in society by being quite innovative. In 1914, at the outbreak of World War I, she used X-rays to help patients on the Western Front or soldiers who had been injured with shrapnel or bullets to locate the bullets. And this is Marie Curie here, and she had these, about 20 of these with other women, and they drove up and down the Western Front, and they took X-rays of injured soldiers, and it allowed surgeons to locate the foreign bodies and then operate on them and remove them. And it's said that she contributed to saving up to 900,000 troops' lives. So she did this for 4 years, and really a very clever piece of work, because X-rays really hadn't been used for medical uses that long, about 10 years, when they were first used by William Röntgen. So it's a fascinating use of taking imaging to the patient for the benefit of the patient. Just to remind ourselves that the World Health Organization says that only 25% of the world's population has access to imaging or X-rays. And this is where ultrasound is now being developed, as it can be handheld, or they're becoming more available, and ultrasound can fill this void for 75% in certain cases, in certain scenarios, for the absence of imaging or access to imaging, particularly in developing world or third world situations. And as I mentioned before, Canada and Australia are really areas where modern medicine really meets remote, austere locations, such as the outback, and such as in Canada, in the middle of Canada, away from the coasts. Most of the populations of Australia and Canada are really around the coasts, and in the centre of Canada and Australia, there's some very remote areas. But there are modern doctors practicing modern medicine and using ultrasound to make decisions and triaging patients. And here's a map of the world, just showing that what we take for granted, certainly in the UK, is the access to good diagnostics. But there's lots of areas in the world where there's actually no diagnostic information, particularly in the centre of these large continents. And let's just to get some perspective about ultrasound, the origins of ultrasound. Well, it's supposedly, I mean, there are many claims to who invented ultrasound. It's based on sonar, but this is an obstetrician called MacDonald, and with his colleagues Brown and McVicker, they developed on base of sonar the use of ultrasound to examine patients. And these were huge machines, and they were for obstetricians. And they developed to look at the fetus or the baby in utero. And some other doctors then took this innovative work and started using all over the body, including the liver, the abdomen, the chest. People like Dr. Hilton Meyer, David Cosgrove, they were really took this work and took it from the bench to the patient. And I was lucky enough to be trained by Hilton Meyer, who really was quite pioneering and wrote a lot of books and was well known in Europe. And in fact, I was telling a colleague this morning, I was invited to give a talk in Europe. I was only a registrar. I'd won a prize at an ultrasound meeting, and I got invited by a doctor to give a talk in Belgium. My wife came along, and I gave a talk on the presentation I had won the prize in, but I shared the platform with David Cosgrove and Hilton Meyer. And at the end of the meeting, it's quite clear that these two doctors who had really helped pioneer ultrasound were really almost celebrities. Everybody in Europe knew them, everybody at this meeting knew them, and it was quite interesting to see how their work had influenced these European doctors and how well known they were. And ultrasound answers brought out a smaller unit, handheld, and this has paved the way for bedside ultrasound and point of care ultrasound. And this is Moore's law. It means that every 10 years, as the technology and the computing power increases, the size of these units gets smaller. And now we have handheld ultrasounds and can be used at the bedside in a host of settings, from the ambulance to the ITU unit to A&E. And this is I've got one of these in my office. It's a handheld butterfly. And I've done 3 or 4 cases using this, going to A&E and using it for certain things when I suspect a DVT, or up to ITU, and the CT has shown a possible DVT. I've gone up and confirmed it using this iPhone. It's quite, the image quality is improving. The cost is coming down. These are about £1,500 now, so they're in the range of doctors being able to afford them themselves. I've got no conflict of interest. I've got no connections with any of these companies. So the visual stethoscope, the anatomy and pathology, that's what it's really based on. And we can examine a whole host of anatomical systems: chest, abdomen and pelvis, soft tissue and bone injury. Of course, I mentioned before thrombosis, triage of high-risk pregnancies, and triage of trauma patients. And I've mentioned before, we can use it in failures on ITU, looking at for renal obstruction and biliary obstruction. And we can also examine the eye. It's so versatile, and people with chest pain, I've mentioned before about intimal thickness, how it can be a stratification of risk factor for patient with heart disease. And then for use in bone injury, it can differentiate between soft tissue injury and bone injury, and this is a fracture here of the rib. And there's a subperiosteal collection of blood. There's loss of continuity of the cortex, and these cannot be seen on chest X-rays, and these are incredibly painful and life-changing in the short term because of the pain. And you can see non-displaced fractures on ultrasound. And here's some more fractures. This is a hip fracture. There's a fracture through the subcapital region, and there's fluid, which is blood in the capsule. Again, I've got a comparison of the fibular fracture. And this can be very useful in remote areas where you have actually no ultrasound, no X-ray. You can use ultrasound to triage patients into bone injury and soft tissue injury. Bone injury would go to the hospital for management. Soft tissue injury would stay locally for rest, ice compression and elevation. Non-displaced fractures can be seen on ultrasound by in the presence of trauma, an effusion of the hip or blood in the hip, and that can be used to screen patients who've fallen on their hip. And of course, in remote areas, we can use it to triage patients for obstetrics into high risk and low risk pregnancies. So if it's a low risk pregnancy, they could be delivered locally, the babies. And if it's high risk, then it goes to a tertiary centre. And things that ultrasound can determine is whether there's how many babies there are, whether the patient's breech baby, so number of pregnancies, the position of the placenta. If it's a placenta previa, again, that's a high-risk pregnancy. If the baby's dead or alive, and the amount of amniotic fluid. So it can be very useful to differentiate between high-risk and low-risk pregnancies, and this is where it's most likely to have a huge impact. And of course, all mammals are made of soft tissue, and even can be used in zoos, and if the elephant can benefit from an ultrasound. And I'm just going to go back now, and I'm just going to talk very briefly about go back to the map of the world So just to talk about, say, in China here, so they use ultrasound to screen patients for hepatomas. In China, they have a high incidence of hepatitis B, and I did my elective in Hong Kong, and we saw lots of patients with hepatitis B, and that unfortunately predisposed them to cirrhosis and hepatomas. And so there's a screening program using ultrasound to look for the presence of hepatomas. So, and when I gave this talk, I actually talked a little bit more in detail about how it changes around the world through the lens of ultrasound. And what I noted when I did the talk and prepared for the talk was that the anatomy is exactly the same all over the world. The environment changes, and so does the pathology. So in this area of China, cancer is quite, general cancer that we have in the West is quite a low incidence, but because you've got the hepatitis B, you have an awful lot of hepatomas, and ultrasound can be useful to screen for that. Equally, I looked in sub-Saharan Africa, they have a high incidence of HIV, and along with that, they're predisposed to TB. And there are doctors in Natal, in the east here, in South Africa, Dr. Heller, and there's something called a FASH scan, where they use ultrasound to triage patients between normal and abnormal. And what they're looking for is patients with HIV who could have TB as well. The prognosis is very poor, but you can use ultrasound to look for nodes, fluid, and they do a 6-point scan looking for nodes and fluid, so supraclavicular pleural effusions and ascites. And that's quite an innovative way of using ultrasound. Equally, as I've mentioned before, in places like Australia and Canada, when you're in very remote areas here, you have ultrasound. A patient's possibly got a sprained wrist. You can examine it with ultrasound and decide whether it is actually a sprain or it's a fracture. And if it's a fracture, it can be sent to a hospital, and if it's just soft tissue injury, it can be managed locally. So again, I cannot reiterate how versatile ultrasound is in many settings, in many clinical situations, and many systems. That's I'd like to thank you for listening to my talk on developing world ultrasound. Thank you. Ultrasound in primary care, and if you certainly in the UK in primary care, you have